Thank you, Althea, for that lovely introduction. I'm very excited to be here and have such a wonderful group here. Just to get to know a little bit about you, how many of you are parents of students here? Oh, okay, some. How many of you are alumni? Oh, quite a bit. And how many of you just came for interest in the topic? Okay, great. So I'm Mary Fox. I worked a very long time, a little bit about myself, as a nurse in practice, probably almost 20 years. And very late in my career, kind of mid-career, decided I wanted to go back and to school and do a PhD. And so this was my interest, really was around bed rest. And so I'm going to talk to you about that today. I'm going to give you an outline, a background on aging and risk for functional decline. And then I'm going to give you a historical perspective on bed rest that took me down into the stacks at the University of Toronto's libraries before the time when everything was on the internet, and I pored over old books, old journal articles, and had a great time doing it. Then I'm going to move kind of to the current day about the forces that are limiting mobility, movement, and perpetuating bed rest during illness. I'm going to talk about three forces at the individual level, at the organizational level, and at the societal level. Then I'm going to go into future directions for research. So we all know our population is aging. Canadians age 65 and older, they represent right now only 14% of the population, but they represent 40% of all inpatient hospital days. Wow, that's quite a bit compared to the representation of the general population. In 31 years, 22% of the population will be over the age of 65. And 1/3 of all older adults will be over the age of 80. I'm hearing an echo here. I don't know if, yeah, I figured if I'm hearing it, the audience is hearing it. So let me know the thank you in the back there. Okay. When I wanted to do my study, my PhD, I was really focused on the loss of functional abilities. And during an illness, a person can lose the abilities to independently function in day-to-day activities of daily living, like getting dressed, walking, going to the bathroom. And we know that when a person goes into the hospital who's over 65, 35 to 65% of them experience functional decline in the hospital. That's quite a large number. And this is higher with age. People who are older, as we age, they're even more at risk. People with chronic health conditions, particularly people with dementia. And at home, we know there's a risk of functional decline that starts before people go into the hospital. Because often people just don't go into the hospital, they're sick. There's a period, right, where they're trying to decide, do I need to go to the hospital? I'm not feeling well. And then during hospitalization and after discharge going home for the first month, if people don't recover those losses that they experienced during those 2 periods, they're unlikely to ever do so. And we know that these are preventable losses. They're related to practices like bed rest, like treatments such as catheters, drugs, that restrict movement and kind of reinforce bed rest. So I was really interested in why. Why is this happening? But I kept hearing from everybody, nobody's really going to care about old people in bed. That was the message that I kept receiving. But every time I talked to people in my practice, because I was still practicing at this time, they told me about their experiences with their relatives. I worked as a nurse. I worked as a head nurse. I worked as a nurse manager. Families would come to me and say, you know, my relative went to the acute care hospital and they're in bed. Or they went to complex continuing care and they're in bed. And we know that there are a lot of risks of bed rest associated with functional decline. And functional decline itself, it affects a person's whole life, right? It affects their mood. It affects their recovery. It prolongs it. They stay in the hospital longer because they're not ready to go home. They're more likely to be admitted to a nursing home. They're more likely to die, and it increases the cost of care. So I was really interested, what's going on? And what is our history around bed rest? I didn't even know the term bed rest because I started practicing at a time where mobility was really reinforced, and I didn't know what to call it. I had to get the librarian, and I said, I'm not finding anything in the literature. And she said, use the term bed rest. It's back in the history, and you'll start finding it, and I did. And so until the mid-1800s, the bed was really a place only for sleeping. And only the very ill went to their beds during the daytime, and they did so with really great reluctance. Florence Nightingale, do you all know who Florence Nightingale is? Yeah, everybody's shaking their head. So I looked through the notes, her notes on nursing, and what she had to say is very, very reflective of what was going on at that time, pre-bed rest. She said, to a sleeper in health, it does not signify what the view is from his bed. He ought never to be in it except when asleep and at night. The case is exactly reversed with the sick. She acknowledged that they were in their beds often, and often prisoners to the beds. But she said, even they should be as many hours out of their beds as you are in yours. Perhaps you can take them out of bed in the afternoon. So this kind of suggests that, to me, that being up for about 8 hours when you were ill in your home, so this was when people were in their homes, they should be up for a total of about 8 hours a day. Then I found, looked through the medical literature and found some work by John Hilton. Now, he was a prominent British surgeon, and he wrote a book on the influence of mechanical and physiological rest. And he started saying that, people really should be in bed when they're sick and when they're having surgery, when they're ill. But that was interpreted, according to Browse, as he criticized everybody for saying, well, John Hilton's teachings were interpreted as putting the whole of every patient to bed, and in many cases, forgetting about them entirely. I also found out that around the 1870s, Mitchell coined a term called rest cure. And the other night I was watching a movie, and it was in the 1800s, and one of the characters said, "Oh, this woman, she's on rest cure," and I was able to explain what rest cure was completely. Rest cure was a treatment for nervous disorders, particularly in women. They stayed in the bed. It was a complete sequestering of the body, the mind, the spirit. They couldn't read, they couldn't write. They were completely in isolation except for the one-on-one attention of the nurse. And this was picked up by psychiatry and remained the treatment for about 40 years. But what I really saw when I was in those stacks was that, with the rise of the hospital as a place, like they really proliferated in the early 1900s, as the place to care for people who are sick. So we're coming out of the home and into hospitals. Bed rest just went rampant. It was now considered the best practice for a number of illnesses and treatments. And so what I did is I decided, let me see what nursing had to say. And I went back to a very popular textbook, even still today, the textbook of the principles and practices of nursing. And I found a quote, starting in 1924. The same quote appeared in 1933, in 1939, and in 1945. And it was, ward patients are in many hospitals awakened at an early hour. The day is long and may be monotonous and dreary, or the patient may have passed through various trying ordeals and be exhausted by pain, discomfort, by the long day in bed. Oh, you're spending the long day in bed. What was going on here? So I read all of these passages, and what I found out was bed rest was really considered vital to preserving life. There was a real dilemma going on in nursing and medical literature at that time. How do we help patients conserve the energy that they need during illness and their treatment? Getting up at this time, even elevating the head of the bed, this was the exact word, was a form of exercise that could threaten energy, that could expend energy and threaten life. So people, the medical and the nursing community were very, very worried about people dying while they were ill, and they needed to conserve their energy for this. Back then, you needed a physician's order to raise the head of the bed. Isn't that interesting? So lying flat in the bed was considered, that's how patients were in bed back then. And in 1920s, I started to see some doubts. There were a few articles discounting the benefits of bed rest. 1922, there was an article that talked about the changes in bone from disuse associated with bed rest. 1929, muscle atrophy, muscles weakening. But there was very little discourse in the medical literature, and there was none in nursing. Then in 1944, there was a more pronounced rejection of bed rest by medicine. People were starting to question it. And the Journal of the American Medical Association published a symposium of 6 articles discounting the benefits of bed rest. And you can just tell by the titles what these authors thought. Every title has the abuse. We're abusing bed rest. There was one article by Harrison and talked about patients with cardiovascular diseases. And back then, the kind of research that was done was very much an observation in practice. This physician noticed how his patients who were from minority groups and couldn't afford to go into the hospital seemed to be doing better than his more wealthy patients who could go into the hospital and be on bed rest. So there was a beginning of a discounting of the benefits. These articles were followed by an editorial with commentaries from 13 physicians who weren't yet ready to give up bed rest. They were still questioning, what do you mean we shouldn't keep our patients on bed rest? The overriding theme of all of their commentaries was, how do we balance activity with rest? And they were very, very clear that this remained the physician's decision. And they were to decide when somebody should get up out of bed, when the head of the bed should be raised. And the problem was one of how to maintain energy so that life could be preserved, which is in the physician's domain. In 1947, we started to see a change in medical discourse. Asher published an article on the dangers of going to bed. Now, he ended his article, and you'll never see this today, he ended his article with a poem. And the poem is, look at a patient lying in bed. what a pathetic picture he makes. The blood clotting in his veins, the lime draining from his bones, the skybala stacking up in his colon, the flesh rotting from his seat, the urine leaking from his distended bladder, and the spirit evaporating from his soul. And then he ends his poem with, teach us to live that we may dread unnecessary time in bed. Get people up, and we may save our patients from an early grave. Do I even need to say more about what Asher thought about bed rest? Although, Asher acknowledged that bed rest, even though he said this, he also acknowledged that bed rest has a role in comfort and healing, but he really believed that physicians were overdosing, he used that term, overdosing our patients on bed rest. And he was highly critical of both medical and the nursing community. And what happened in the 1950s is that a lot of research went into space science. And what I found out was space scientists use bed rest as the Earth model to test the effects of weightlessness in space. Because you're no longer having the gravitational force along the longitudinal axis of the body when you're lying flat. And what they found out was that bed rest affects every single system in the body, muscles, skeletal, bone, the nervous system, which includes cognition, our ability to think. What they also found out was that where bed rest, where it has huge implications for patients in hospital, is that it has a very big effect on the cardiovascular system. And what this leads to are orthostatic symptoms. Have any of you ever seen, probably some of you remember when the astronauts came back from space? Did you ever see the TV footage? What did you see? How did they seem? Pretty feeble, yeah. They carried them, yeah, they carried them. They were very, very weak. Now, the astronauts were up in space and they were there for a long time. So we may not, think that, people they're not up in space. They don't stay in bed that long, right? But how many of you have ever been in bed for a couple of days when you had the flu? How did you feel when you got up? Weak, dizzy, right? Well, that's called orthostatic symptoms. And it's the hallmark of bed rest conditioning. And the thing is that it happens within 48 hours, it can happen. And to recover it, you need to be up out of bed. You need to be upright out of bed. And the recovery takes up to 3 times the duration of bed rest. So if you've been in bed for 3 days, you can expect you're not going to start feeling better until about 12 days later, right? So this is the beginning of the questioning that bed rest, it doesn't conserve energy. What it does is it promotes deconditioning. So we start now in the 1950s to see a major shift in the nursing literature. So that same, we see from bed rest as a panacea for all ills to ambulating out of bed as a minimum best practice, getting the patients up out of bed. And so when I got to the 1955 edition of the same textbook, that exact same quote that I showed you earlier was still there, except the long day in bed was changed to the long hours in bed. But still today, we see a disjuncture between this evidence and practice. Nursing and medical texts now focus on mobility. In the 1955 edition, it was the first time I had actually seen the term mobility appear in the index. It didn't even appear anywhere else in the prior editions. But hospitalized patients now, they still spend a lot of time in bed. And when I mean bed, I mean lying down. I mean on stretchers, in lazy boys. That's not sitting up in a chair. That's in a reclined chair. It's the same. It's the same as bed rest. Some studies have found 71 to 83% of time for an older person in hospital is spent lying down, and up to 40% of all older people are in bed at least 24 hours in a hospital. So throughout now my academic career, I've been wondering what forces are limiting mobility and perpetuating bed rest during illness. So I'm going now to talk about those three factors that I told you about. When I was first doing my dissertation, and I was giving like presentations at the places where I work, and I talked about, personal factors, nobody believed me. Nobody's like, how could anybody want to stay in bed? There's no way, not our patients in this hospital, they want to stay in bed. It's not because they want to stay in bed. So I'm going to talk to you today about some things that I found out. I also questioned, how could anybody want to stay in bed? I thought it was terrible, and I didn't think anybody could make that decision on their own. So I interviewed about 66 patients who were in complex continuing care. That's what complex continuing care facilities are. It's where somebody goes after they've been in acute care. They're not ready to go home yet. They need to recover. They're getting some rehab. And I also did studies in acute care hospitals. When I interviewed the people in complex continuing care centers, hospitals, I asked them, who's making this decision for you to stay in bed? And 72% of them told me that they were making the decision to stay in bed. And 70% wanted to continue to stay in bed. And I was wondering why. And how could somebody want to stay in bed? And so this one woman said to me, she said, you'd think, Mary, that being in bed all the time would make you feel less tired. But it's just the opposite. It makes you feel more tired. And she went on to say, I got up the other day to go to the chapel. I couldn't stay up more than an hour, and I begged to go back to bed. Wow, begging to go back to bed. So we thought, well, there's something going on here. There's something about this dependency on the bed. And what that is a compulsion to go back to bed soon after getting up and limiting your upright activities. And this is explained by the effects of bed rest on the cardiovascular system that I told you about earlier. And the implications for people in hospital is that, like I said earlier, it starts very, very early. It's experienced when you get up, but it gets better when you go down, right? When you lie back down. So it almost makes it's logical sense that I should be lying down, because when I get up, I feel awful. I feel weak. I feel feeble. I feel dizzy. I just don't feel good. And so this dependency on staying in bed comes about from the belief that lying down is now the only way to manage the symptoms. and the fears that accompany those symptoms. Fears of falling because of the symptoms. When we're sick, we're weak. We're really afraid of injuring ourselves. People say that time and time again. We're fears of exacerbating our sleep and our health problems, right? We're tired. It makes sense to go back to bed. We need to rest. We need to sleep. When I talk to people in the complex continuing care hospitals, they said to me that getting up would require too much energy and it would tire them out. They said things like, I'm just too tired to get up. I have no energy to do anything. Others told me, I'm not tired. I don't really need to be in bed today. It lets me get by. Being in bed lets me get by the next day. So now we're starting to see not a conservation of energy to preserve life, but a conservation of energy that is going to be needed in the next day or the next couple of days for future activity. Everyday activities were defined as depleting energy. And here's one gentleman's, what he said to me. He said, because the shower day is a form of activity, and by the time it's over, I'm pooped. I never thought of having a shower as a form of activity. But see how similar this is to those narratives I told you about earlier that I read about in the nursing and medical literature. What they also told me is that they learned about this as a strategy in acute care because they started staying in bed when they got admitted to the hospital. And they said it worked. So it really is a self-management strategy. They're very, very difficult. Try changing any strategy that we all know, going on a diet, trying to exercise more. That's very, very difficult, right? We've all tried to change things in our lives. It's very difficult. When something is seen as a strategy that works and it's managing how you feel, it's very difficult to change that. What we found in the acute care medical studies, and we went on to medical units and interviewed people who had just been admitted. And we asked them about, their preferences for different interventions, different activities. And 15% of them said they would prefer just to exercise in bed. 20% said that progressive walking was not appropriate and they wouldn't comply with it. Wow, that's for something that's standard practice, getting up and walking, we would expect everybody to say, yes, let's get up and walk. Some people out in, these are Boltz and other authors, have found that many older people believe walking is inappropriate during illness, especially in a hospital. Hospitals are dangerous places. You could fall in a hospital. They're fast moving. Other people have expressed the need to stay in bed and focus on getting better, not walking. I need to stay in bed. I need to rest. The other individual factor is families. And this is a graduate student of mine who did this study. Families want to do right by their relatives, right? They come from, I put these pictures up, and somebody has to get the phone. Families come with a long history. So a family member could be that little girl right there. And that's what she remembers about her father, right? And she wants to do right by her father. And she may think that her father needs to rest. So what we found here was some families help a lot with their relatives to stay functioning during illness, and some don't understand the need to get up. They think their families need to rest. And in this study, we found that some call the nurses and instruct them to keep their relative in bed. Or when they got to the hospital, they instructed the nurses to please put my relative back to bed. He needs to rest. So those are what we found in terms of the individual forces. Now I'm going to talk about the organizational forces. And this was a large study, and we looked at factors related to nurses' abilities to help older people stay functional during an acute care hospital stay. So we surveyed a random sample of over 2,000 nurses in 229 hospitals across Ontario. And we asked them questions about their practice environments, the care they give to older people and older people's families. We asked them about their interprofessional working relationships, collaborations. We also asked them what they thought about the overall quality of care that people receive at their hospitals and older people's families. And we asked them about, we gave them a little test. They were great sports. They did the test on geriatric knowledge. And then we held 13 follow-up focus groups with 57 of the people who filled out the surveys from 18 hospitals. And we asked them to reflect on their experiences. We also held separate focus groups with the nurses who did the best on the test. On the belief that they would be able to share their experiences with us, having worked with older people, having learned about what their own knowledge needs were. So what I'm going to tell you might sound kind of negative about them, but it really was their reflection on hospitals, their reflection on their own practices. And what they told us was there's a huge emphasis in hospitals on system efficiency. And they expressed a lot of difficulties helping older people stay functioning because of health system flow and cost containment initiatives. And so I don't know if any of you have seen this month's Toronto Life. You all have. And so what it says there, hallway healthcare. This woman spent 47 hours for surgery in Sunnybrook ER. That's a real big issue in Canada right now. Canada ranks last in timeliness of care and 10th out of 11 countries in overall efficiency. So making the healthcare system more efficient really is a major concern for policymakers. But what the nurses told us in this study was that the emphasis in hospitals is on moving older people quickly through the system, not supporting their function. They also said, and the average age of the nurse was about 47, so they could reflect on when they first started nursing. They felt that their leaders, these are their managers, their directors, were very disconnected. They felt badly for them. They said they're under huge pressure to improve lengths of stays, ER, wait times, and these were tied to financial incentives and disincentives. But they described them as closed off in their offices, working in silos, lost in spreadsheets. If anybody had told me when I worked as a head nurse, in 20 years, you're going to be lost in a spreadsheet, I would say, come on, no way. That's not the job of a head nurse or a manager now they're called, right? But this is the kind of pressure they're under. So what the nurses said is their leaders are charged with devising initiatives to improve flow, to save money, but they're too far removed now from practice to make these decisions and to take into account older people's vulnerabilities in this system, which they described as busy, as moving fast. They said things like, it's in you go, in and out you go. Out you go, the flow, the flow. And so what we saw were some, from them, what they shared with us, were some unintended consequences of these system efficiency initiatives. So I put a little cartoon up there, and it says, of course we're fully staffed. 1 nurse to do the work, 2 to report on the work, and 3 to monitor the reports on the work. And that's what, this is just one example, that we had tons of examples. And they talked about the way they chart now. They have tick sheets. But they said, we seem to have a tick sheet for everything. They said, this is a corporate initiative that has just gotten to be too much for us. They're purposeless, all-consuming. They unnecessarily pull us away from care. And they resented them, particularly when the purpose was just for benchmarking for the ministry. One nurse really summed this up really nicely. She said, we have to sign in on every patient. 7 patients, that's how many patients she has to take care of, every hour. That's 84 times. I have to sign my name and check off 3 different spots. And then she went on to explain, they don't get locked. The next force I'm going to talk about within this theme of institutional forces are interprofessional team collaboration. So getting people up, walking them, is really a multi-professional endeavor. It's not usually the first person to get you up if you're on a medical unit, because physiotherapy is not standard practice here in Ontario for medical wards. It's a nurse. But nurses expressed that they need physiotherapists. They talked about team accessibility on the weekends and evenings. So somebody could get admitted to the hospital on a Friday evening. Okay? They could stay in bed. Say they get admitted at 4 o'clock Friday. And they have a functional problem. They're at risk for functional decline. And then they could stay in bed. Maybe the physio might get to them by end of the day Monday. That's more than the 48 hours I told you about earlier. So they said, sickness, it's 24/7. Older people decline during this time. They also talked about team rounds. In hospitals, the different professions get together very quickly. They go through everybody. And these are the primary venue for making decisions and advocating for patients, older patients, advocating for their families. Nurses explain that because of system efficiency initiatives, they're now excluded. They're not going. Most of them said, we're not going to team rounds. So we're not at the table. We don't have the opportunity to advocate for our older patients who, we're the ones getting them up, we're the ones seeing them every day. Maybe they need to, maybe I need to let everybody know how important it is that the physiotherapists get in there. They also talked about hierarchical relationships. Remember I told you that it's the physician's decision to decide whether the head of the bed gets raised, the head of the bed, the patient gets up out of bed. They talked about a culture of not questioning decisions that may undermine an older person's functioning. And I saw this difference. During my sabbatical, I went to NYU and saw tons of hospitals. They were wonderful at NYU. They brought me around to different hospitals and in Brooklyn, in Manhattan, in Pennsylvania, everywhere around there. And what I saw the team rounds, the nurses were there. Why has this patient got a catheter? Asking the physician. Other hospitals, I saw that, well, if the physician doesn't write an order to take out the catheter, the nurses just take it out. Anybody who comes with a catheter to the medical unit or the surgical unit, it just gets removed unless the physician orders to keep it in. So it's a little bit different than what we do here. But I definitely felt the difference in the culture. There was more a culture of questioning there. Cost containment was another issue. So they explained that physical care is very heavy, it's very difficult. It requires manpower, it's muscle. And they felt that they didn't have sufficient help. And they acknowledged that we're supposed to get them up in the chairs. We're supposed to take them and, walk them a little bit. But very often, they'll be in that bed 24 hours. It's true. You can't get them out of bed because you don't have anyone to help you. They also talked about equipment. People who are sick, they sometimes can't, they need help. They might need a cane. And so this lack of equipment was what we saw was especially prevalent in the non-teaching, the non-academic hospitals. Now I'm going to go into our very last one, which is societal forces. And I have two wonderful birthday cards up here. And I want to ask you, it's the first one says, yippee! I'm 5, wow. Invite sent out, friends on their way, your favorite costume to brighten your day, fun and excitement, all the day through, all this and more is wished just for you. Wow, that's so exciting, eh? I want to be 5 again. So what does this say to you? Turning 5 is something to be celebrated, right? What does turning 40 mean? Or turning 59? What does it say to you? You're old. Hide it. Don't tell anybody. It's something to fear. I'm turning 40. I'm surprised. Only 40? And so I want to talk a little bit about ageism now. And what ageism is, it's discrimination based on age, right? It's culturally contingent. We know that. We know some societies revere older people, right? But our society positions older people as weak and burdensome. It's not something you want to go into. You don't want to go into working with older people. When I decided to go into geriatrics, I had worked in general surgery, urological surgery, and in Montreal, and I decided I'm gonna go into geriatrics. You know what people said to me? That's a real waste of a good nurse. That's a real waste of a good nurse. So what I'm going to tell you is that nurses acknowledge themselves, and this is probably true for most professions. Nurses see older people at their most vulnerable states, their most dependent. Come to the hospital, they're not up walking around, they look sick, right? They look sick and they look old. And it reinforces ageist attitudes and beliefs. But what they told us older people's care is really complex. I actually have to be a better nurse to work with older people in the hospital. I need more knowledge. I need more skill. And why they need more knowledge and skill is that with an older person, they often come in with multiple chronic conditions, along with the acute condition they're experiencing, along with age-related changes, which reduces their physiological capacity. They're often on many medications. And so it gets hard to identify what's causing this problem that brought them into the hospital and what's causing the problem of the change in their condition. I'm going to give you an example about delirium. Delirium is kind of when, I could be teaching today, I could be talking today, and then tomorrow I'm in the hospital and I have this acute confusion. I couldn't get up and give this presentation. I may think the nurse is my sister. I'm not oriented. That's very hard to understand what's going on. Is it a problem in my head? Could be that I have a urinary tract infection. And that is the symptom I'm presenting as if something's wrong in my head, but the problem is in my bladder, right? What they said to us, they recognize that it's very complex. It needs more knowledge and skill. But if I go on and get this knowledge, what it does for me in the hospital system and society in general, it allows me to give care that has very low status with a segment of the population that doesn't have a lot of respect and isn't highly valued. One nurse said it's not very sophisticated. It's probably the bottom of nursing. And I see this all the time in my students. They get placed. I always ask them, how many of you think you're going to be a geriatric nurse? And everybody says no, right? And then when I start telling them the stats and I say, you're all going to be, unless you go into pediatrics or maternity, you're all going to be geriatric nurses. So ageism, it permeates our society and it filters into healthcare. It filters into hospitals. And so what are the consequences of ageism? Sorry. Older people's care is undervalued. I'm not saying people do this, healthcare professionals do this intentionally. In our sample, only 1.1% had the certification by the Canadian Nurses Association in gerontological nursing. 1.1%. And what happens is when you don't value something, you don't attend to it. You don't go out and say, I'm going to spend my evenings and weekends getting more education in gerontological nursing. So what happens is they start to draw on knowledge, when they don't have the knowledge, in ageist attitudes and beliefs about older people is confused. So this one nurse who, she explained to us, when delirium, that I told you about earlier, it's not recognized, older patients, they're not mobilized. They're sedated, they're restrained, whatever needs to be done to keep them physically safe. So what are the future directions after everything I told you about now? We know we have an increasing prevalence, a rising prevalence of chronic diseases in an aging population, right? We're now moving care with system efficiency initiatives. We're trying to move care back to the home, right? Don't want to keep people in the hospital. Hospitals, unless they really need it, are not a great place for people. But we're discharging people quicker and sicker. What does this mean? This means there's going to be a tremendous pressure on informal family care. It also means hospitals are going to admit the most at-risk patients. So I think what we need to do, and what we're doing in a study right now, is we need to better understand the perspectives of older people and their families on rest and physical activity in the early discharge period. Because people are getting discharged, they haven't completely recovered what brought them into hospital. So we're asking them things like, we're giving them surveys and we're interviewing them. Are you prepared to manage recovery? Are you prepared to manage functional recovery? What do you think about these interventions of getting up and walking? Is it something you can do? Is it something you feel that you could take charge of with your relative who's sick at home, recovering at home? We need also more research on hospital-wide interventions. And we need to embed in them the promotion of value and respect for older people. We need to challenge these forces. We also need more research on up and walking. How much? People always ask me, tell me the absolute minimum I need to do, because I'm not going to run a marathon. I'm not feeling well. Tell me what's the minimum walking, the minimum time I need to get up and stay up in order to maintain my health and my functioning while I'm recovering. So that's the end of my presentation. I want to thank you very much for coming today and